Diabetic Keto Acidosis, or DKA. It's one of those high-stakes medical emergencies where every single second counts. It's this complex metabolic firestorm that really demands a calm, clear, and totally systematic response. So in this explainer, we're going to break down that exact approach, using a simple but really powerful mnemonic to guide us through every critical step.
Okay, so what exactly are we dealing with here? DKA is diagnosed using this classic triad. First up, hyperglycemia. The blood sugar is just sky high, way over 250 milligrams per deciliter. Second, you've got ketosis. The body's just churning out huge amounts of these things called ketones, which are basically a toxic alternative fuel. And third, acidosis. Well, those ketones are acidic, and they push the body's pH into a dangerously low state, below 7.3. Spotting these three things is the absolute first step in identifying the emergency.
So how does this whole crisis unfold? Well, it all kicks off with a severe lack of insulin. Without insulin to let glucose into the cells for energy, the body basically panics. It starts breaking down fat at this completely uncontrolled rate. This process, it's called lipolysis, and it floods the blood with fatty acids. The liver sees all these fatty acids and converts them into ketone bodies. These ketones just build up way faster than the body can clear them, and that leads directly to that life-threatening metabolic acidosis.
All right, to navigate this complex emergency, we need a memorable game plan, and that is where the mnemonic FIKGAPS comes in. It's brilliant. We're going to start with the first response, then move to the balancing act, cover the all-important safety net, and then finish up with resolution and prevention. This is our roadmap for managing DKA safely and effectively. Okay, let's jump right into our first section, the first response. This covers the first three letters of our mnemonic, F, I, and K, which, you guessed it, stand for fluids, insulin, and potassium. These are the immediate, life-saving moves that will stabilize the patient.
What's really striking here is just the sheer scale of the fluid problem. A patient in DKA is profoundly dehydrated. We're talking a typical water deficit of about 100 milliliters per kilogram of body weight. So for a 75-kilogram adult, that's a staggering 7.5 liters of fluid loss. This is the first fire we absolutely have to put out.
So how do we fix that massive deficit? Not all at once, but with a very carefully structured plan. This table shows the standard protocol using 0.9% saline. We start aggressively, giving 1 liter in the very first hour to restore blood pressure and get the kidneys working again. Then, we methodically replace the rest of the volume over the next several hours. It's all about controlled, systematic rehydration.
And this right here, this is exactly why that control is so important. If you push fluids too quickly, especially in younger patients, you can cause a rare but potentially catastrophic complication, cerebral edema, which is swelling of the brain. That's why we follow a staged protocol. It brings the body back into balance without causing a dangerous osmotic shock to the brain.
All right, with the fluids running, we move on to I for insulin. The key here is a fixed-rate intravenous infusion, typically at 0.1 units per kilogram per hour. And it's so crucial to understand this. Its primary job isn't just to lower blood sugar. Its number one job is to shut down the metabolic engine that's producing all those toxic ketones.
So what is this insulin actually doing? Well, as you can see, it's a multi-pronged attack. Its number one job, like I said, is to suppress ketogenesis. Then it lowers the blood glucose and helps correct those electrolyte imbalances. Notice the specific targets. We're aiming for a steady, controlled decline. And that last point is vital. You have to continue the patient's own long-acting basal insulin. That provides a steady foundation underneath the IV infusion.
Now for K, potassium. And this is a really crucial, often misunderstood concept. We call it the potassium paradox. A patient's initial blood test might come back showing a normal or even a high potassium level. This is a dangerous illusion. The acidosis has forced potassium out of the cells and into the bloodstream, making the number look good. But in reality, as you see on the right, their total body potassium is severely depleted from massive losses. This means we have to be proactive. We know that as soon as our insulin starts working, it's going to drive all that potassium back into the cells, causing the blood level to plummet. So to prevent this, as soon as the serum potassium is below 5.5, we start adding potassium chloride directly to the IV fluids. We are anticipating the drop to prevent a life-threatening heart rhythm problem.
Okay, we've initiated the first response, and we've stabilized the patient. Now, we enter the second phase, the balancing act. This covers the letters G, A, and P, as we navigate glucose, acidosis, and find the precipitating cause.
So here's another delicate balance we have to manage. The insulin infusion absolutely has to keep running to clear the ketones. But as it does its job, the blood glucose will inevitably fall. To avoid causing hypoglycemia, a whole new emergency, we act once the glucose drops below 14. At that point, we start a separate infusion of 10% glucose. This lets us keep treating the root cause, the ketosis, without letting the blood sugar crash.
Now for A, for acidosis. It might seem intuitive to just give bicarbonate to correct the low pH, but as this slide clearly states, that's almost always the wrong move. It's a dangerous shortcut that can cause way more harm than good.
And this slide explains why. Giving bicarbonate can actually worsen acidosis inside the central nervous system. It's a phenomenon called paradoxical CSF acidosis. Essentially, you can correct the blood pH while trapping acid inside the brain, making things worse where it matters most. It also increases that risk of cerebral edema. We only even consider it in the most extreme cases, when the pH is below 7.0. Otherwise, we trust that our fluids and insulin will allow the body to correct the acidosis all on its own.
Next up is P for precipitating cause, and this is absolutely essential. DKA doesn't just happen in a vacuum. It's almost always triggered by something else. Most often an infection, missed insulin doses, or sometimes it's the very first time someone finds out they have diabetes. We have to be detectives here, performing a full workup to find and treat that underlying trigger. Because if we don't, the DKA simply will not resolve.
We've covered the core treatments. Now we need to discuss the final letter of our mnemonic, S, which stands for the safety net. This covers all the essential supportive care and vigilant monitoring that wraps around our entire treatment plan to prevent complications.
So what does that safety net look like? 3 key interventions. First, thromboprophylaxis. The severe dehydration in DKA makes the blood incredibly thick and prone to clotting, creating a very high risk of a fatal thromboembolism like a pulmonary embolism. So, prophylactic heparin is totally non-negotiable. The other 2 are about monitoring and airway protection. A urinary catheter to closely track fluid balance, and a nasogastric tube if the patient is unconscious to prevent aspiration of stomach contents into the lungs.
This checklist highlights the level of vigilance required. Managing DKA is not set-it-and-forget-it medicine. We are constantly monitoring. As you can see, glucose and ketones are checked hourly, blood gases and electrolytes every 1 to 2 hours, and we are frequently assessing their neurological status for any early subtle sign of that dreaded cerebral edema. This intense monitoring is what keeps the patient safe as they navigate this crisis.
We're now at the final phase of our protocol. The crisis is resolving, and our focus shifts to resolution and prevention, confirming the DKA is over and planning the safe transition back to normal care. So how do we declare victory? We don't guess. We have clear, objective biochemical goals. Resolution is officially achieved when blood ketones have fallen below 0.6 millimoles per liter and the venous pH has normalized to above 7.3. Once we hit these numbers, we know the metabolic storm is past, and we can safely transition off the IV insulin infusion and back to the patient's regular subcutaneous insulin regimen. And that brings us to our final and perhaps most crucial point. The acute crisis is over, but our work isn't done. The real question now is, how do we prevent this from ever happening again? This is where the focus shifts from the high-dependency unit to education, reviewing insulin techniques, ensuring a clear understanding of sick day rules, and empowering the patient with knowledge. Because the ultimate goal isn't just to treat this episode of DKA, but to prevent the next one.